Today's presentation is going to be looking at the examination for neurophysiological issues, specifically reflex inhibition and segmental facilitation. I used to consider axoplasmic flow as either a neurophysiological or a neurological problem and try and treat it both. However, I'm really leaning towards this being neurological simply because of the mechanical nature of its causes. So I'm going to leave this out. We'll cover axoplasmic flow in another video, and we'll see how that basically screws up the entire thing sometimes, trying to determine which it is. And as I say, I'll do differences and similarities between AXT and these two conditions. To try and do them all now is going to be way too confusing, I think. So it's a reasonably long presentation, so it's in two parts. Part one will be looking at similarities and differences between the two and how they show up during clinical examination. And also, I'll give you a background to this. And then the second part will be actually on the examination itself. But first, the similarities. There are not that many similarities: strength, tone, and the effect of wobbling. So strength, they're both weak. Different types of weaknesses, but they're both weak. And the same with tone. They're both abnormally toned, one hyper, one hypo, but they're both abnormal toned. Input of proprioception, which we've shorthand to wobble, improves both of them. A quick word on wobbling. We'll talk about it more later on, but a quick word on wobbling. I'm using the term wobbling now because I don't want you to start thinking this is a graded mode. There is nothing graded about this. All you have to do is put in non-nociceptive input into the joint to either defacilitate or de-inhibit. It doesn't have to be graded, doesn't have to be rhythmical, it just has to be lower than to cause discomfort. If you cause discomfort or pain, it's counterproductive. You'll make these things worse, not better. So you can use that if you want to. If you can make them worse by wobbling, it's the same as if you can make them better by wobbling, but the patient's going to be a lot happy with you if you make them better with wobbling. So keep the wobbles down, keep them careful. Could deal many more differences and similarities. So both, as we said, I have weakness, but in the segmental facilitation's case, this is non-fatigable. That is, unless you really make it work and work and work and work and work, then any muscle will become fatigued. But within half a dozen or even 10 contractions, this will not fatigue any more than a normal muscle will. It's just weaker than it should be. It's also non-breaking. So breaking weakness you see in reflex inhibition, and this is a sudden giving way of the muscle that's being made to contract. It's like painful weakness without the pain, just suddenly gives way. The best way of finding this, the most sensitive way of doing this, is to do an eccentric contraction from the end of range into the range, not further into the end range, but further into the range at which you're at the end of. So if I'm rotated to the right, I'll be pushing it to the left, and you'll see it suddenly break. So generally speaking, it'll initially, if the test is done fairly casually, you'll see a reasonable resistance and then suddenly give way. If you test it really carefully, which isn't a bad idea in the spine, and you put a mild push into it, so the end of range, so a mild push that way, you'll feel it give a little bit on the initial push and then hold, and then it'll give way as you push it into the range. So you'll get about halfway maybe, and then it'll suddenly give way. Tone changes, palpate the muscle directly, hyper, hypo. You're better off palpating segmental facilitation, tone changes in the multifidus, right up against the spine, push deep into the gutter and feel for the multifidus tone change. This, of course, won't be an issue if you're dealing with reflex inhibition because it's local tone. So you can have a dysfunction in the spine itself, a facet joint or an unconvertible joint, that results in hypotonicity, that is reflex inhibition, and that you'll also feel in the multifidus, but you'll feel it around the muscle that's affected. For sensation, this is generally difficult to pick up, and it's often there's no real change. For hyperesthesia, you can pick this up with palpation testing. So pushing deep, one side will be more tender than the other. It may not be much, but if you push hard enough, it will be present. Often it's just not worth doing this. Whereas reflex inhibition, there is no sensation changes. Deep tendon reflex, this is brisker in that segment than it is on the other side or on other segments. Not hyper-reflexive. I can't state this enough. This is not hyper-reflexive. There is no clonus involved. It's just a bit brisker, but it should be. And finally, the distribution, segmental facilitation is segmental and local. Excuse me, reflex inhibition is local. Remember what we said though, the effects of segmental facilitation are more profound, more centrally, and less profound as you move away from the spine. Got nothing to do with what's causing it. It's got nothing to do with the source of the facilitation. It just is more profound towards the spine than away from it. Also, you can have different degrees of reflex inhibition and different degrees of segmental facilitation. So these signs we're talking about can be extremely obvious or very subtle. It's not nice and clean as a table would have it. This is just an idealization of segmental facilitation and reflex inhibition. So let's have a look how these would show up on an examination process. Now, the tests, strength tests, scratch tests, etc., down the middle are the tests you can do. The ones you should do are the ones in blue. The ones in yellow, DTR and sensation testing, really not that important. They tend to show up when you're doing, for example, a neurological exam, and these can confuse you. So I wouldn't do these in the neurophysiological exam because they're not necessary. They're difficult to pick up anyway, and they're often apparently negative. So if we start with a strength test, first off, you find weakness, and you can think about the distribution of the weakness and its quality. If the distribution is segmental, then it's segmental facilitation. If it's local around the joint, then it's likely to be reflex inhibition. The quality of the weakness, if it's breaking, it's local reflex inhibition. If it's breaking, rather, it's reflex inhibition. If it's non-fatigable, it's segmental facilitation. Scratch test is well worth doing. Along the side of the spine, as I say, you're looking for either an area that doesn't turn red or is a narrower band. So it comes down fairly wide, then thins in and comes out again. It can be a very rapid change, so you need to look for it very quickly after you scratch. So if the scratch test is positive, it indicates segmental facilitation. If it's negative, it may not be segmental facilitation and it's reflex inhibition. Tone testing, this can be done either in place of or first, before scratching, or after it. It's about how much input you're putting into the segment when you do these things. So multifidus tone palpation, if the tone is hyporeflexive, then you have reflex inhibition from a spinal joint problem. If it's hyper, then it's segmental facilitation. If the tone remains normal, then you have neither going on, probably. Deep tendon reflexes, if it shows up, brisker is segmental facilitation, normal is reflex inhibition. Sensation testing, hyperesthesia, segmental facilitation, and normal is likely to be reflex inhibition. And then wobble testing, if they work, it could be segmental facilitation or reflex inhibition. If they don't work, if there's no help, then you either have neither condition or the muscle is atrophied, in which case wobbling isn't going to make that much difference. It could also be that this is a neurological problem, as I say, neither segmental facilitation or reflex inhibition. That could be that it's a neurological problem that will not respond to wobbling. Okay, so that's the similarities, differences, and how they show up during an exam. Next, part 2, we'll look at the examination itself and what you can expect to see. Again, this is all idealized. We'll talk about the complications of this in the second part, but it is idealized.